Hey everyone, and welcome to today's Explainer. We're tackling a really critical and frankly fascinating area of pediatric care today: neuromuscular conditions. Our goal is to clearly differentiate three complex presentations. We're talking cerebral palsy, hypotonia, and spinal muscular atrophy, while also hunting down their crucial shared care principles. Okay, let's dive into this. So, here is our roadmap for the Explainer. First up, cerebral palsy. Second, hypotonia. Third, spinal muscular atrophy. And we'll wrap it all up with our shared care and safety synthesis. All right, starting right off with Section 1, cerebral palsy, the static blueprint. To really grasp cerebral palsy, or CP, we absolutely have to understand the difference between a static brain injury and a growing child's evolving needs. By definition, CP is a non-progressive impairment of motor function, muscle control, and posture. And honestly, the key word you've got to lock in on here is non-progressive. Think about the brain injury itself like a static blueprint. That blueprint was drawn up with some errors, maybe due to prenatal hypoxia or an early infection. And listen, that blueprint doesn't change. It's done. But the child is like the actual building being constructed from that blueprint. So why does this matter to us? Well, because even though the brain injury isn't actively getting worse, the child's functional care needs will absolutely evolve and become way more complex as they grow taller and heavier. That physical growth just puts more and more mechanical demand on their already compromised muscles. When we look at how CP actually presents in the clinic, we categorize it conceptually. Spastic or pyramidal CP is by far the most common. We're talking up to 80% of cases. These kids present with hypertonia, intense rigidity, and often this classic scissoring posture in their legs. Now, dyskinetic and ataxic types make up the remainder, and those feature more involuntary movements or balance issues. But honestly, we don't need to get bogged down in heavily memorizing every single subtype. Instead, just focus on recognizing that the vast majority of these patients are dealing with profound, exhausting muscle tightness and spasticity. So how do we spot it early? The hallmark developmental cues are things like delayed motor milestones, persistent primitive reflexes, like a Maro reflex that just refuses to go away when it should, and an abnormally early hand preference. Now, what's really interesting about this slide is realizing CP isn't just a motor issue. Because of that stiff posture and poor muscle control, these children are at an incredibly high risk for feeding and swallowing difficulties, including scary stuff like choking and gagging. They also frequently have to manage vision, hearing, and speech impairments, as well as seizures. It's truly a multi-system management challenge. Because that spasticity is such a massive hurdle, medication management is a core part of CP care. And you've really got to notice the distinction here. On one hand, we have systemic oral medications, like baclofen and diazepam. These are central-acting muscle relaxants. They wash over the entire body, which means you have to constantly monitor the child for systemic side effects, things like profound drowsiness, fatigue, and even hepatotoxicity. On the other hand, we have botulinum toxin A, better known as Botox. This is a localized intramuscular injection. It's honestly brilliant for a child whose spasticity is largely limited to, say, just their legs. It reduces the spasticity in a targeted muscle group without sedating the entire child, though, it can cause some temporary weakness right at the injection site. Moving right along to Section 2, hypotonia, the floppy infant. So we are completely shifting gears here, transitioning from the high-tone spasticity of CP to the exact opposite end of the spectrum. Hypotonia is very commonly colloquially referred to as the floppy infant. Visually and tactily, these babies have flaccid extremities and just incredibly poor head control, presenting with significant head lag when you try to set them up. If you perform a vertical suspension test, which just means you try to lift the infant by placing your hands under their arms, they completely lack the muscle resistance to stay propped up. It results in this really terrifying slip-through feeling for the person holding them. And naturally, this total lack of tone translates directly into massive respiratory and feeding risks, because they just can't coordinate swallowing or take deep enough breaths. So the crucial point is that we cannot, I repeat, cannot use the terms hypotonia and muscle weakness interchangeably. They are totally distinct. Hypotonia is reduced resting muscle tone. It is a decreased resistance to passive movement. Think of it exactly like a loose rubber band. Even when it's just sitting there doing nothing, there's absolutely no tension. Muscle weakness, on the other hand, is a reduced ability to generate active force or movement. Now, a child can have one, the other, or both, but a really sharp clinical eye is required to distinguish resting tone from active strength. The absolute most important takeaway for hypotonia is that it is a clinical sign, not a final diagnosis. If you see a floppy infant, it is a giant flashing red flag telling you to hunt for the underlying cause. Is it a genetic disorder like Down syndrome or Prader-Willi syndrome? Is it a primary muscular condition? Was there an acute hypoxic event during birth? Or is it a progressive neurologic disorder? Which actually leads us perfectly into our next topic. Section 3. Spinal muscular atrophy, the fading signal. Unlike CP, which we established as static, our third condition, spinal muscular atrophy, or SMA, is a profound progressive condition. It's a genetic autosomal recessive disease caused by a mutation in the SMN1 gene. Basically, this mutation leads to a deficiency of the SMN protein, which then causes this relentless, progressive degeneration of motor neurons, specifically the anterior horn cells in the spinal cord. I want you to think of it as a fading signal. Motor neurons are like the electrical wires that stimulate voluntary skeletal muscle to contract. As these specific neurons progressively die off because they lack that crucial protein, the muscles receive less and less electrical signal. And without that signal, the muscles literally just stop working and begin to waste away. Let's move to and see how this builds into a truly devastating clinical cascade. Step 1, the motor neurons die. Step 2, this presents visibly as progressive limb weakness and muscle atrophy. But here is the critical connection you can't miss. The muscles we use for breathing and swallowing are also voluntary skeletal muscles, controlled by these exact same motor neurons. Therefore, step 3 is an inevitable decline in swallowing and feeding ability, followed quickly by step 4, the onset of severe respiratory failure. The limb weakness and the respiratory failure aren't just random separate complications, they are driven by the exact same fading signal. Because of this intense cascade, ASMA care relies incredibly heavily on interprofessional support. Pulmonologists are absolutely essential for managing that respiratory decline with things like BiPAP and chest physiotherapy, while gastroenterologists will frequently place G-tubes to safely manage nutrition and prevent aspiration. But there is some incredible hope here. We now have emerging therapies like nusinersen and risdiplam that actually increase functional SMN protein in the body. Even more revolutionary is onasemagene apaparvovec. That's a gene therapy that literally delivers a functional SMN1 gene to the patient, which is drastically improving survival rates and motor function. It's a real game changer. And finally, Section 4, Shared Care and Safety Synthesis. Okay, so we've explored a static brain injury, low tone, and a progressive genetic disease. Now, despite their vastly different pathophysiologies, they share some incredibly important overlapping daily care requirements. First and foremost is aspiration prevention. Managing poor swallowing and weak coughs is a daily critical battle. Second is positioning and alignment. We use orthotics, standers, and highly specialized wheelchair seating just to support their frames. Third is contracture prevention through relentless passive range of motion and physical therapy. And finally, psychosocial support. And listen, this means not just educating the parents, but recognizing that these kids need to be kids. Promoting distraction through play, adapting outdoor activities, and fiercely supporting their cognitive development independently from their motor delays is absolutely vital. But if there is only one single thing you take away from this entire explainer, let it be this critical safety alert. If a child with any of these neuromuscular conditions suddenly develops increased work of breathing, a weak cough, new choking during feeds, or cyanosis, you drop everything. The immediate absolute priority is airway and respiratory support. Because their muscle reserve is already so compromised, respiratory failure happens incredibly fast. There's no time to wait. And this brilliantly illustrates our final point. When a child with a neuromuscular disorder suddenly declines, you never ever get distracted by long-term mobility or developmental concerns. The airway is always the top priority. Understanding these core mechanisms, whether it's the spasticity of CP, the floppiness of hypotonia, or the fading signal of SMA, empowers you to anticipate those emergencies before they happen. Thank you so much for joining me today, and keep that curiosity going.